Good morning, friends. Continuing with our series of infected non-union managed with rail plate, here is a case of periprosthetic distal femur infected non-union. This is a 70-year-old lady who had undergone total knee replacement on the left side a year ago. Unfortunately, she suffered a roadside accident leading to a compound fracture distal femur periprosthetic on the left side. She was operated for the same and presented to us with complaints of pain, inability to bear weight, with multiple pus discharging sinuses over the left distal thigh. This is her immediate post-operative X-ray showing a plate in situ for a periprosthetic distal third comminuted compound fracture, and that's her X-ray on presentation showing a broken plate with sequestrated bone in between. She was planned for a stage 1 radical debridement. A segmental defect of 8 to 10 centimeters were created after removal of all the dead bone. The bone was maintained to length and alignment using a distal femur plate. The dead space was managed using a cement spacer along with therapeutic antibiotics, which included vancomycin and imipenem 4 gram each per bag of cement, and the samples were sent for pus culture. She grew methicillin sensitive Staph aureus. She was given appropriate IV antibiotics for 10 days, followed by oral antibiotics for another 2 weeks. Her CRP and ESR came back to normal at 3 weeks. She was given a drug holiday of 3 weeks after the antibiotics, at the end of which the CRP ESR was normal. There was a 12 centimeter gap, the skin was well healed, there was no pain, and patient was bearing weight with walker. Now the question is, what next? Patient went on with her activities, denying any further surgery as she was absolutely asymptomatic, and 6 months later she came with this. It was an anticipated fatigue failure of the plate because of the non-biological reconstruction. At this point of time, her infection had no signs of flaring up. CRP SR was normal, skin was normal. Now what? What are the options? The options discussed with the patient were megaprosthesis, bone transport using Elizarov ring fixator, or anything else which we can think of, maybe a masculase technique. This is what was done. The thought process was that there was an increased chances of infection with a megaprosthesis. Elizarov is something which the patient plainly refused, and masculate technique for an elderly lady, the issue was harvesting an adequate amount of bone graft. So the patient was restabilized with a long plate, and a bone transport was planned from proximal to distal with an anterior rail. We can enumerate the various advantages of this technique over classical Elizarov, which can be a less bulky frame, decreased fixator time, better rehab, and overall a better patient compliance. But this was the first time such a thing was being used for a periprosthetic infected non-union, though there was an existing literature for its use in femur. At 3 months of follow-up, the patient was infection free, the transport was going on, a good regen rate could be seen as this on this X-ray. At 6 months, the distraction phase was over, a good regen rate was formed, and the transported fragment was docked distally. At this point of time, patient was taken up for surgery. The transported fragment was fixed with 2 screws to the plate, and docking site cancellous bone grafting was done. Patient was mobilizing after this surgery with the walker. Unfortunately, 6 months down the line, she suffered a simple twist and broke her plate. The X-ray shows a very good consolidation of the regen rate, but a docking site non-union. The infection markers were normal at this point of time also. She underwent a nail plate with an intramedullary nail along with an augmentative plate. No graft was added as the distal fracture was well vascularized. That's this patient at the latest follow-up. The fracture is well healed and she is back to her full activity. Again, this case reiterates the beauty of rail plate technique for a very complex periprosthetic infected non-union in a fragile old lady. Thank you friends, and keep watching this space for more such videos.